just want to start again, so waiting for the people who are coming in the room. So we will continue with the issue regarding ovarian tissue cryopreservation. And the first part of the session will be dedicated to the technical issue. And we will have a debate between the two experts I already presented this morning about vitrification versus slow freezing technique. And it's my pleasure. You, sir? Oh, yeah. Oh, no. It's my pleasure to welcome again Debra Gook for the first presentation about slow freezing technique. Thank you very much.
Thank you. Again, thank you very much for the invitation to present some data on slow freezing, and I hope I'll be able to convince you that slow freezing is the way to go if you're setting up your program and starting to freeze tissue. So I'll cover today morphological evidence of preservation. I'll also cover functional preservation using xenografting or clinical data that we have on those. Show you the data for multiple cryoprotectant methods, that this is reproducible between patients and between labs, that the tissue that we then have is suitable for grafting, and I'll also cover the safety, the duration of storage, and talk a little bit about cryoprotectant levels in the tissue. So for those of you that don't actually do any of the freezing of the tissue, freezing ovarian tissue is actually much more complicated than most of the other material we freeze in ART, like blastocysts and oocytes. So you can see here that there's a difference in size between the oocyte that's in the primordial follicle, those stromal cells, and the granulosa cells. And what happens with the slow freezing method is that it's not ideal for any one of those particular cells. What we're doing is making a compromise with the rates that we're doing, where we compromise some of the cells from each of those types to actually get the tissue to preserve. So around the world, there are 3 different cryoprotectants that have been the ones that have used in conjunction with slow freezing: DMSO, ethylene glycol, and propanediol. And some of the methods also have sucrose in that dehydration mix. There are some methods that don't add sucrose as well. And then they're all using a slow rate of freezing, where they drop down and do a manual seed. And the seed is different with each of these different cryoprotectants. And this is just some pictures from our freezing process, where we use propanediol and sucrose. And you can see from the picture at the bottom that with slow cooling, we've preserved the morphology of the oocyte, the pregranulosa cells that surround that oocyte, but we haven't actually achieved good survival of the stromal tissue and the collagen bundles. But it was also reassuring to see that within the oocyte, that the mitochondria have been preserved with the freezing method that we use. So this is important for those to then go on and function. So the morphology only gives us just an indication of what might be surviving. It doesn't give us any indication of whether it's capable of function. So we then move on to look at xenografting of the tissue. And this is where we take that very small piece of tissue. We've placed it under the kidney capsule in a skid mouse, and then after about 4 or 5 months, we can see those human follicles growing within that tissue. We then looked and saw that we had multiple follicles that had grown, as you can see in that bottom left panel, and that unfortunately we can't use ultrasound on our mice to know when to give them a HCG injection, but you can see when we randomly gave HCG that some of these oocytes go through and mature and appear to be quite normal. We then went on with our method and xenografted tissue from multiple patients and using multiple mice so that we could then check the reproducibility of our freezing program and our method. And you can see by just looking down those columns that we've got large numbers of follicles that have been preserved, and many of them went through to metaphase 2. A similar investigation has been done with the DMSO method and also with the ethylene glycol method, where they showed histological and electron microscopy evidence of intact oocytes, again the mitochondria within those oocytes and those pregranulosa cells with the slow freezing. Sam Kim from Kansas also then went on to show, after xenografting of tissue that had been frozen, slow frozen with the DMSO procedure, that he could actually find some corpus luteum, and that he also found a couple of mature oocytes after his xenografting. So this is Sam's grafting of his tissue following DMSO freezing at a heterotopic site in a patient, where he then went on and collected oocytes from it. So that clearly showed that the tissue, there were preserved primordial follicles within that tissue, and they could function right through to the metaphase 2 stage and then produce embryos. So here's a summary of the different cryoprotectants. You can see down each side the DMSO, the ethylene glycol, and the propane diol method. And these are patients where the tissue has been grafted heterotopically so that we could clearly see that the tissue was functioning and had follicles preserved in that tissue. These have all been oocytes collected via an IVF retrieval method, and you can see that there are mature oocytes, and that these mature oocytes from each of the method could go on and produce embryos, clearly showing that we could preserve function with the slow method right up to the embryonic formation. This is our work with our slow freezing and then heterotopic grafting, where we've grafted tissue at the abdominal wall, and we then, when we went back to do our second graft in this patient, you can see the tissue has actually formed into a little sort of mini ovary sitting there on the abdominal wall. We obtained 2 oocytes from that tissue that then went on and produced twins. So this is unequivocal evidence that we can show that the primordial follicles within that tissue had been preserved and were capable of going right through to producing a full-term birth. Similar evidence is now out there for the DMSO and the ethylene glycol procedure, where again they've had patients that have had a bilateral oophorectomy, they've placed the tissue back, and they've achieved births with that tissue. So it clearly shows that the tissue is capable of development right through to births. We also know now that the method of freezing is quite robust, because the group from Denmark have also shown that they can take that tissue out, refreeze that tissue, then they've placed that into their xenograft model mouse, and they've actually shown that there are still follicles present in that after that second freeze, and they can develop to that secondary stage. So it's a very robust method. So this is evidence on the longevity of function with each of, again, those different cryoprotectants with the slow freezing. And this is data where they've then looked at how long the patient has continued to have function after grafting. And you can see that they're functioning for quite a long time, which again means that we've got lots of primordial follicles that have been preserved in the tissue, and that they're all quite capable of going on, and these patients have multiple menstrual cycles for years after they've had the tissue back. This is a bit of a summary of the The main groups around the world that have used the slow freezing method have grafted their tissue and their pregnancies. This is not all the births in the world. This is just a bit of a summary of them. And you can see that for each of the methods, again, the DMSO, the ethylene glycol, and the propane diol method, that there have been births from all of those methods, and that we've now got reasonable numbers of births from each of those methods. This is also a summary that came out last year of a systematic review of all of the graft procedures using the slow freezing. And you can see in this there were around 123 births, but we know from Dro this morning and also from Klaus that those numbers are much higher than that number. But this is what's been in the literature. We also know with the slow freezing that we can successfully graft tissue that's independent of size and still achieve pregnancies. So again, a very robust method for freezing tissue. What about the safety? We need to reassure our patients that the method that we're using is safe. As Klaus said before, we freeze in vials for the slow freezing, and because of the thermal mass of those vials, we know that they can be easily kept in vapour storage for a long period of time without any change of temperature. This then decreases the risk of having any cross-contamination within the tank. So we always keep our vials in a vapour phase tank. We know that because we're also using vials that they're suitable for then transport from one centre to another. So we can then also reassure our patients that they don't necessarily have to have their grafting of their tissue with us, that they could transport that back to another clinic if they wished. We also know that there is no impact of the duration of storage. So if your tanks are maintained appropriately, here are 4 papers where the tissue had been kept in those tanks for a long period of time, thawed, and then transplanted and subsequently resulted in births. We also, Klaus showed this earlier this morning, that there is no impact of the duration of storage on those follicles being alive within the tissue. This is some interesting data that came out from one of the Japanese groups where they looked at the amount of cryoprotectant that was present in the tissue after they completed the thaw. And you can see with the slow freezing that there is still a little residue of the DMSO in their tissue after they've completed the thaw, but there are very high levels still present in the vitrification tissue. And so we need to also take this into account when we're actually doing our thaws, that we allow enough washing out of the tissue before we actually do the grafting. But again, it would suggest that the carryover of cryoprotectant then into when we do the graft is minimal with the slow freezing method. So basically, I've shown you quite clearly that we are using the slow freezing method, that we've quite successfully frozen primordial follicles. This is the evidence with the xenografting and also with our heterotopic grafting. That there's success with multiple methods. There's no actual comparative data between methods, but I think there's sufficient data out there now to show that whichever cryoprotectant you use, they all seem with the slow freezing to be quite adequate. That it's a very reproducible and robust technology, that many labs can use it. We use it teach it as being a fairly robust method between clinics. We've got numerous births, multiple clinics. We can have success with each of the cryoprotectants, that there's longevity of function, suggesting that we're actually preserving large numbers of follicles within this tissue with the method, and that it's a very safe method for us, one in the storage, but also that there's a reduced level of cryoprotectant in that. So I'd just like to acknowledge my group that does all the tissue freezing with me and some of my collaborators. Thank you.
Thank you very much for this very clear presentation and robust data. So I will welcome now Sherman Silber for discussing the vitrification technique.
Well, let's see, I pressed this thing, right?
Is this the presentation you want to use?
Yes. Okay. Thank you for asking. Well, so I hate debates because I usually wind up agreeing with the other side. And I think both of us are right, and I'll just explain to you why. We prefer vitrification, but we have a long, long history with slow freeze going back to 1997. And to summarize everything, our slow freeze tissue, when we transplant back, works just as well as our vitrified tissue. There's really no difference in the result. But we prefer vitrification because it tends to just be easier. It's easier to teach, it's less clumsy, you don't need a freezing machine. And since most IVF labs now don't even have freezing machines, it may be easier for IVF labs to participate in these processes. So let me just go through this a little bit. As I said, our results are equally good with both vitrification, but vitrification just is easier and quicker, and I'll show you why. Now, the simple concept of vitrification is no different, really, than slow freeze. Slow freeze is a matter of removing water from the cell gradually by having preferential ice crystal formation on the outside of the cell, increasing the osmolality so that it draws water out. And you gradually draw water out because of the slow computerized freeze, and ultimately you've reduced the water content of the cell from 70% to about 30%, and then it actually will vitrify. Now, there'll be some crystals in there, but you're relying on vitrification when you do slow freeze. It's just a different way of getting vitrification. Now, on the left, you see vitrification just as pure vitrification technique. And on the right, you see if you don't do slow freeze properly, you're going to wind up getting ice crystals destroying the inside of the cell. Now, with vitrification of the oocytes does require a little bit of speed because, I mean, the whole thing is based on once you have the vitrification media, you want to plunge it in liquid nitrogen quickly. But it also relies on being very careful about osmotic shifts. Now, I'll have to quote Masa Magee, who originally developed all this, that ethylene glycol and DMSO are not really toxic. We don't have to worry about toxicity. They appear to be toxic because of the rate of osmotic shift. And if you control the rate of osmotic shift so that it doesn't damage the cell, then they are not toxic. And so slow freeze vitrification completely avoids any ice crystal formation by using a very dense concentration of cryoprotectant and an ultra-rapid speed of cooling. Slow freeze relies on partial and gradual removal of water from the cell by encouraging ice crystal formation, preferentially on the outside of the cell. The freezing point is higher outside the cell because of lower osmolality, thus drawing water out of the cell, reducing water from 70% to 30% as the cell cools. So ultimately, slow freeze is an indirect way of doing vitrification. You increase the viscosity intracellularly by drawing fluid out. And the survival of the cell depends, again, on enough viscosity to allow vitrification intracellularly rather than ice crystal formation. Not as efficient because there's 30% water still left, and the viscosity isn't as high as you get with our vitrification technique. However, it's going to work perfectly for small cells. For primordial, it won't work well for eggs, or even for embryos, it's very poor. But for the 30-micron cells in primordial follicles, which is all you care about in the ovary, it's just perfectly okay. There's no difference in result. So the slow freeze protocol, I'll just summarize, this is what we use for embryos, but it's just a minor variation for tissue. Instead of 0.1 molar sucrose, you would use something like 0.2 molar sucrose. And it's just the same protocol, and it's just a gradual reduction of temperature, allowing preferential seating on the outside of the cell. And then the thaw is similarly thaw, and we thaw it down the same way originally we did with eggs and embryos in the old days. Now, with vitrification, we go very, very, very carefully with osmotic shifts, and first we make an equilibrium medium that's 7.5% DMSO and 7.5% ethylene glycol with 20% protein. And then after 15 minutes and gradually increasing concentrations, we watch the embryo contract and re-expand and sink, and it all has to happen at a moderate speed, or else there will appear to be toxicity from ethylene glycol because of the rapidity of osmotic shift, but no intrinsic toxicity. Then you place it into 15% DMSO, 15% ethylene glycol, just enormous concentrations, and 0.5 molar sucrose to really draw every last bit of water out. And you have such a viscosity inside, and then you have such a rapid cooling, not 0.3 degrees centigrade per minute like with slow freeze, but literally 23,000 degrees centigrade per minute. And you just dunk it immediately in liquid nitrogen, and with that fast freeze and a super high viscosity, you just get vitrification, which is no ice crystal formation whatsoever. I mean, none at all. And this is what the embryo would look like. It's easier to show this in an embryo than tissue. 5 minutes later, it's shrinking, and then it's beginning to re-expand at 10 minutes, and at 12 minutes, it looks pretty normal. It re-expands, and then it sinks because it's filled with the high viscosity media. So 1 minute only at 37 degrees, it floats and then sinks. Don't touch until 1 minute, does not contract or expand. Then in the DS for 3 minutes at room temperature, it expands and sinks, and then in washing solution. But that's just what thaw observations are like also. You want to make sure that there's a slow and gradual osmotic shift. And there are various ways of doing it that you can make the shift not as originally was done in various culture dishes with different concentrations of cryoprotectant, but you can just do it by swirling it around from one level to another and letting it sink and swim, and so you get a more and more gradual osmotic shift. And then, of course, we all know that when you want to thaw, you have to go very, very quickly, just like when you want to dump in liquid nitrogen. So this is the original method that Masa described. Now, really, we don't really even bother getting the extra fluid off. We just make sure to dump it directly into liquid nitrogen. So what we thought was bad before probably isn't so terrible. So I'm going to go to the next and show that then you probably know this, we have to be very fast with it. Now, this is with embryos and eggs, but you have to see how much easier it is with ovarian tissue. I mean, this is tricky. You need a microscope, and you need to be very good with your hands, but let's see if we can, yeah, very, very quick with your hands, but with tissue, it's much easier. All that you need with tissue is to have a higher concentration yet. You wind up with 40% rather than 30% concentration of cryoprotectant. We determined that if you have lower than 40%, you're going to have some damage done and not complete vitrification. And in fact, you can see that just here, that intermediate vitrification gives you a lot of ice crystal formation, and then you get no vitrification at all with the normal concentrations. But with a high, very viscous material, I mean 20% and 20% is a 40% total of cryoprotectant plus 20% serum, is a very viscous medium, and of course viscosity is the whole secret to lowering the freezing point. So the ES solution is the same for embryo or oocyte vitrification, 15%, 7.5% and 7.5% with 20% protein. But the vitrification solution is just more concentrated. It's a total of 40%. That's really the difference. And you leave the tissue slices in the solution for 25 minutes, and then you place it in vitrification solution, and all you have to do is wait until the thin tissue slices fall to the bottom of the centrifuge tube. So there they are on top of this very, very viscous vitrification media, and then you just watch them gradually, and after about 25 minutes, they float to the bottom. And once they float to the bottom, they know they've fully absorbed the vitrification solution. There they are at the bottom. and then you just put them on any kind of a strip. We use a nicer strip now. We use a Kita's platform. It's nicer than this, but the whole idea is to let the fluid drop off. You don't want any fluid on the surface. All you want is the fluid that was absorbed into the tissue. And then you dunk it into liquid nitrogen, and you're done. And it's very simple. You don't need a machine for it at all. So this is just, again, a summary of what I just told you, but I can send the formula to it anytime. It's a very simple formula. And we look at what it, even if we look at and send the tissue to pathologists everywhere, they can't tell whether it was vitrified or fresh tissue. And there's no damage at all to the interstitium. And actually, we found that there was a higher damage from slow thaw, but the amount of damage wasn't enough to make any clinical difference. So with our first studies, we found that with slow freeze, we actually had half as many viable oocytes as with vitrified or as the control fresh, but that doesn't make any clinical difference whatsoever when you're dealing with 200,000 eggs. And so then I showed this before, but it's easy to thaw the tissue. You notice we can have much bigger pieces of tissue than you'd normally put in a cryovial. And we then suture that tissue together with microsurgically with 9-0 nylon. It's all under a microscope. And then we see it becomes one nice piece of tissue, not just a bunch of little pieces of tissue you inject into an ovary, and you're going to get better results. And we already have 31 healthy babies from this technique. And we actually more than 31 healthy babies, 31 pregnancies leading to babies. And you see we have it in a position where she can get pregnant naturally. So our goal is not to want to do IVF later because it's very difficult and leads to pregnancy rates of 20 to 40% maximum. But with this approach, we already have 80%. Now, there's a patient that will talk to you later this afternoon. It took a long time to get pregnant. She was a little worried. It might take a long time because they're going to ovulate every month, and sooner or later they're going to get pregnant. And one patient has 5 babies from the same tissue, not even a different transplant. 4 babies. This patient you'll see tomorrow has 2 babies. But you don't start getting pregnant until a year or so after because the ovary that was an infantile ovary has to come up to normal size. I showed this the other day. Maybe I'll bore you if I show you it again, but this is the very first patient we ever did in 1997. And I told her that I didn't think this would ever work because we're not going to transplant back cancer cells, and we're not going to be able to culture M2s out of that tissue. But she decided to do it anyway. Here we are doing it.
8 o'clock
1997.
in the morning, July 17th, 1997. We're at St. Luke's Hospital. And we're about to do the first case in the St. Louis area of ovarian tissue freezing.
Well, I went too quickly. I should have showed it when she was pregnant. Oh, I didn't do that right. Okay, well, we'll just go ahead. But many of you have seen that already. So she has a healthy baby. She's 44 with a 24-year-old ovary, and she plans to have more. Plus, she's not on hormone replacement. And this is kind of a summary of the first cases that we did, the frozen cases for just cancer, and 76% pregnant with delivery. And you see that 6 were from vitrification, 11 from slow freeze. But if we actually look at, we did many more slow freezes because those are the cases we originally froze. But if you look at, say, the slow freeze, we had the same % result with slow freeze as we had with vitrification. So we have less experience transplanting vitrification because it takes a long time for these patients to come back, 10, 15, 20 years. And we started a long time ago, originally with slow freeze. But it looks like the results are pretty much the same. And even with cancer, you can see that, even with, leukemia, you can see we have 6 babies from leukemia. One of our leukemia patients already has 5 babies from the same transplant. So we actually agree that slow freeze is a good method, and it works just as well as vitrification. But I just point vitrification out to you as an easier approach. It's less clumsy in the laboratory. There aren't any more freezing machines in IVF labs, so IVF labs are more likely to do this for you. And so just in the modern world, I think slow freezing machines are going to be going out of style, and vitrification is just going to be easier, and the results aren't any worse. Thank you very much.
Thank you very much. So please. Oh, okay. So we have time now for discussion about these two different techniques. Is there any question in the audience?
Thank you for your great presentations. I have a question about the size of the tissue that you either slow freeze or vitrify, and if there's any limitations that you find with those techniques, just by personal experience and using the Kitazadu kit as well. Well, we slow freeze in our clinic, just to emphasize that. But I've tried the vitrification kit, and we do have to make it thinner than what we would prefer to do for pediatric patients that have about 2 millimeters of primordial follicles, from their ovarian surface epithelium. So I wonder if you could speak to that, Dr. Silber.
Yeah, so I think that's the biggest difference between the slow freeze and the vitrification is that the thickness of the pieces. I don't think the dimensions, as I showed, are really that critical. It's actually the thickness. So that you don't get ice formation during the vitrification, you really need to have the pieces very thin. And that basically that paper-thin, translucent cortex. Yeah, you agree?
Yeah, the way Debra dissects the cortex for slow freeze is exactly what I'd recommend for vitrification. She makes it very, very thin. One thing about vitrification might not be true of slow freeze is you don't want too big a volume. So we decided we liked big pieces, but 1 centimeter by 1 centimeter by a millimeter was ideal. And as soon as we got over that, like 2 centimeters by 1 centimeter by 1 millimeter, the volume was too big, that slowed the rate of cooling, and the results weren't as good. So for vitrification, you really cannot put pieces of tissue that represent too much volume in there.
So maybe I have a question regarding the learning curves, because as you say, vitrification, you need to really take care about the dissection of the tissue and so on. So you think there is a difference and variability according to the experience of the biologists who perform the procedure in both procedures?
Can you explain to me? I didn't understand through the microphone.
Yeah, so she's basically asking about the embryologist experience in being able to cut the thin slices. Variability. Yeah.
Well, all I can say is there's no better. I'm just embarrassing Debra, but the way she dissects the cortex, which is the toughest part of it all, is fantastic. So you want to be good at that, whether you do slow freeze or vitrification. So I don't think it's technically more difficult to learn vitrification. I think it's easier, actually.
Yeah, I guess having shown a lot of people, and I guess from talking to the people at the workshop on Sunday, the ability to get that cortex down to 1 millimetre is quite difficult. And it does take some experience and time for you to be able to do that for slow freezing even. And so our embryologists find that quite difficult to get it thinner than that for vitrification. So we've stayed with slow freezing just because it's got a bit more give and take in it than vitrification. So from going from one embryologist to another, and we know that the ovarian tissue varies between patients, the density and the fibrosity of it, and so it can be quite difficult to always get it down below that sort of millimetre that's required for vitrification. So yeah, so we've stuck with slow freezing even though we're capable of doing both.
Thank you.
I just want to follow up on what Monica said, and that is that for the very young patients, the cortex is a lot thicker. So Can you walk us through getting down to 1 millimeter? Let's say it's 2 millimeters thick. So are you cutting it in half and keeping both halves of the 2 millimeters? Or do you just discard if you're going all the way down to 1 millimeter thickness, discard anything that's getting cut or scraped off of it?
I couldn't understand what he said.
Yeah, so for the young patient,
Did I get that right, Monica?
to get down to a millimeter because of the cortex and the way it's formed.
Right.
So
Yeah, it
would
goes,
you keep both?
yeah, from ovarian
both
surface
the
epithelium
top
down
millimeter
2
of the
millimeters
cortex
will
and
be
then
all the primordial
millimeter
follicles
underneath.
for the youngest
Okay.
patients. We keep
So,
ours 2 millimeters.
Debra translated for me, because through the loudspeaker system, even my hearing aids don't seem to do a very good job, and some of them actually Bluetooth to your hearing aid, and then I understand perfectly, but it's very hard. So Debra explained, I think I understand. With very young patients, you mean prepubertal patients, where it just looks like you don't even see much of a medulla, it just looks all solid. Is that what you're saying? Yeah, well, sure. It's hard to really know. I mean, that's almost like a horse ovary, where the whole thing is, the horse ovary, it's all cortex, it's all solid, and it's like a baseball, and the primordial follicles are all very tightly packed into that horse ovary, and that's the same as a prepubertal ovary. So, yeah, I think you slice it sharply with a knife, and then you freeze everything.
Yeah, so I agree with that we would prepare the top millimeter and then prepare the tissue underneath and freeze both. Just because we get very little tissue from those patients, and we might get an occasional antral follicle in those or a secondary as well. So we figure we might as well freeze it all. Yeah.
Yes, Claude?
I just wanted to add that indeed you do make the tissue 1 millimeter, but then you can slice up the ovary as a sausage. You have to make it 1 millimeter, but you don't take out the medulla. You just use all of it, because it's absolutely correct. There's follicles all over the place, so you may as well just take it all.
I don't understand through the loudspeaker. What did he say?
So he was saying that you freeze. He was agreeing.
Oh, he's agreeing. Okay,
yeah.
okay. If you agree, then.
There is a last question.
I don't have a question, just a comment. When we do prepubertal monkey ovaries, the same, and we just take 2 slices. So we actually get 0.5 millimeters on the Stady-Rig slicer, and then take the next slice and vitrify all of it. And one advantage for us with vitrification is that it preserves the secondary follicles in the cortex much better than slow freezing. So if you are going to get into the business of in vitro follicle maturation, vitrification would be preferred.
I don't know what you said.
So she's basically saying the vitrification preserves the secondary follicles better than
Cool.
the slow freezing.
Is that why she likes it? Yeah. Well, for the secondary follicles, I mean, my viewpoint is get it as thin as Debra gets it for vitrification, but then look carefully at the spent media, because that's what you want to do is look at those follicles in the spent media, in vitro mature them. 35% should mature to M2s of good quality, and then freeze those M2s. So I still think the best argument is to make it thin like Debra, but don't throw away the spent media.
You want to comment? No.
Hi, thank you so much for these wonderful talks. Jackie Maher from the NIH and Children's National. I know we're talking about the thickness and transplanting that tissue to the patients, but I was wondering, across the board, different publications for follicle density have used a different area, and I was curious amongst your different institutions what you're using from the depth of that area from the cortex in. So if you're counting your follicles, like are you counting all of the area from that piece of tissue? Are you counting 1 millimeter in? Are we counting 2 millimeters in? And how can all of us across the world compare those numbers if the area is different for everybody? Or the whole piece of tissue if it was like a sausage cut?
Okay, so she's asking about when we do our counts, do we just count that top 1 millimeter for our follicle counts, or do we count deeper?
Yeah, you can answer that.
Yeah, so we just do the count of the top 1 millimeter for our follicle counts. yeah, we do know that we do have some follicles deeper, but most of our patients, we would see that the follicles are in that 1 millimetre, so that's all we've been counting. Klaus, do you want to comment on what you count? Yours is only the 1 millimetre as well, isn't it?
Yeah, I do think that if you concentrate on the first millimeter of the cortex, you get 90% of all the follicles. There may be a few in the medulla tissue, and there is secondary follicles, and there's a few primordial in there, but it's not a lot. So whenever we calculate the density of follicles, it's always just the first 1 millimeter. Of course, you could argue that there is the ovarian surface epithelium, which may be 40 micrometers, 50 micrometers, but that often disappeared during the preparation. So it is the first 1 millimeter. That's where they all are, for all practical purposes.
So thank you very much. If there is no further question, I would like to thank both of you for your excellent presentation and discussion. And I will call the last speaker of the session,